Well, thank you for your kind introduction. Thank you also for the organizing committee for the invitation. And this is my first time in China, hopefully of many, and I have only found very good people and kind people. So we're going to continue with the fertility line. We're going to talk about fertility and uterine health, and we're going to talk about embryo implantation. As you may know, my specialization is in fertility specifically, and I'm very jealous of the function of the uterus, so we need to preserve that function. So let's talk about implantation and embryo implantation and the keys to embryo implantation. So we have a human paradox. We need to reproduce, obviously, and it is critical for the survival of our species, but it is extremely inefficient. So the maximum fecundity that we have is 30%. And if you observe the couples that are having kids or are intent to have kids, they only get pregnant in 16% of the cases each month. So it's really inefficient. And only 50 to 60 pregnancies goes beyond 20 weeks of pregnancy, and most of the pregnancy are lost, and we don't even know. They don't get a pregnancy test, or maybe they have a pregnancy test, but they don't get along with the pregnancy. And 75 of the pregnancy losses are explained by implantation failure. And implantation failure is the limiting step in all the reproductive techniques. So since I was a resident and now 10 years after and now that I'm working, we always perform an IVF, for example, and the limiting step we can control, and we may control the drugs, the stimulation, the ovarian stimulation, the retrieval. We can even perform the best embryo transfer in that patient, but we cannot control the implantation of that embryo. This is a limiting step in those techniques. And we have learned many from the implantation process. And if you look at those graphs, those of the substance that are producing between the embryo and the endometrium are related to inflammation, for example, and they are related to cytokines that are working in together with the embryo and the endometrium to have that process of implantation. So there are some things that may alter that implantation. And we have that black box. Even if we perform an IVF, we have the embryo, we do the embryo transfer and say goodbye, embryo. Hopefully we have news from you on 10 or 15 days, and that's it. We cannot know anything about that. So how can we manage to look at that black box? How can we open that black box in order to see or to comprehend more that process of implantation? And we should manage like that. And the problem is that if we open the box, we don't know what are we going to find. It may be like opening the Pandora box, and all the evils in the humanity may arise, but there's still hope in that box. So there's an interesting model of research in this topic, and it is called about generating those blastoids, those 3D models that are similar to an embryo, in order to look at the implantation. So with this interesting model, we can assess that embryo, well, that structure that looks like an embryo in the site of the embryo. And it may work for example, embryo biopsy training, and even to have that information. And imagine that we have that 3D model, and in the other hand, we have that endometrial model. Imagine that we can assess some endometrium that comes from a patient, like they have hydrosalpinx, or they have recurrent implantation failure or something like that, or even with some woman, that endometrium that comes from a healthy and fertile woman. So if we have both sides of the endometrium and the embryo, we may look at that black box and know something more about implantation. Why I'm telling you those kind of stuff? Because even that we may have a patient, we look in the ultrasound, we may have the best MRI study and the best MRI ultrasound machine, etc. But if we look at that myoma, at that fibroid, and we don't even know if that patient is going to be infertile or not, we will know when they that couple tries to get pregnant, and you look back and they don't get pregnant. But if you look in advance that fibroid, or even adenomyosis, there's a controversy in reproduction that if that myoma is causing infertility or not, and if it's not, it may be not the best idea to treat that myoma or that adenomyosis. So you don't know in advance that process, so that's a problem. And if you want to look at this kind of research that is published, it is really interesting because they look exactly at that model. And if you wonder how an embryo implants, look at that embryo that is growing, that is expanding, and gets to something like a blastocyst stage, and that gets to implant in that model, that 3D model of the endometrium, and it is called an assembloid. And in the other hand, if we may do or perform something like an embryo transfer, and the embryo is not meant to get implanted, or they get the embryo implantation, look how that embryo, it does grow, it does make some movements, but it doesn't implant and it doesn't expand that embryo, that blastocyst that we have. So we may have that kind of information. There's another different point of view in this, and it is also interesting as, well, this is the Castillo de Chapultepec, the Chapultepec Castle in Mexico City. And this article also talks about embryo implantation, and it is called War in Times of Love. And they say something interesting, and it's our different point of view, because they say that, okay, an embryo can't implant everywhere, literally everywhere. An embryo can implant in the ovary, or maybe implant in a scar tissue, or maybe implant in the bladder, even wherever the embryo wants. But when we perform an embryo transfer, it doesn't get implanted. So at least 50% of the cases, even in IVF, even we have an euploid genetically perfect embryo, we cannot implant that embryo. But if we have some scar in that uterus, like for example, some laparoscopy or some surgery in that uterus, or even a C-section in that uterus, the embryo may implant that, and we don't want that embryo to be implanted over there. And we need, of course, in that endometrium or in that menstrual cycle, that we have synchrony between that endometrium that is growing, between the hormones that are secreting in that cycle, and we have only that 5 days of implantation window in order to the embryo to implant. So it is really important. But if we have something that has damaged that uterus, for example, and some surgery or even a C-section, the embryo can implant over there. So it is something strange that is happening, and we are looking at that. And that window of implantation only lasts for that 5 days. And we at the beginning of the Congress, we have some information, or we received some information about the microRNAs and natural killer cells, and all of that cells that expresses when there's some inflammation over that. And if you look at those effects that have those cells that are implanting, we look at, for example, some substances that are natural killers that are present in some of the other pathologies, such as, for example, GPEGF, that we related to, for example, preeclampsia or some hypertensive disorders in the pregnancy. And those substances are shared between recurrent miscarriage and recurrent implantation failure. So there's something happening over there, and if we do something else that harms that uterus, it will be worse for the implantation process. So, as the beginning of the Congress, they also say that the treatment shouldn't be worse than the disease itself, so we have to preserve that function. And there are some tests that were developed in order to look at those substances, in order to see if an embryo is going to implant or not. And they are like endometrial receptivity tests, but scientifically they didn't get along in the reproductive world, because they didn't show exactly what is happening in the cycle that we are performing an embryo transfer. But it was a good research in order to show, for example, the NK cells, the cytotoxic cells, and they tell you, well, the endometrium is receptive, or but it may be old, or maybe not worth not good for an implantation. But the problem with those tests, they didn't get the communication between the embryo and the endometrium, because those tests were performed, for example, in a previous cycle that you are not going to perform the embryo transfer. So they miss that there's an embryo in the embryo transfer, and they miss the communication between the embryo and the endometrium, and those are the microRNAs. So we are still missing those information. And exactly, those microRNAs are the responsible for the communication between the embryo and the endometrium, and they actually did induce some changes in the endometrium that helps that embryo to get an implantation. And those are the tests. You may have seen them, the ERA test or the ERA map test, and there are a lot of tests, but actually something interesting that was mentioned in the previous talk, some about the HOXA genes. They were not included in those tests, so it was, for example, those tests that were altered in the fibroid scenario. They are not actually looked in those tests, so it is actually kind of weird of that. And they also forgot that the gold standard for endometrial receptivity is to have endometrial implantation. So those studies didn't actually look for the implantation of that embryo, and they only look for the genes that were expressed during the implantation process. And there's another problem, the recurrent implantation failure. You can have many embryo transfer in IVF, and they don't get pregnant. And there's an interesting study in that team. Then they say, okay, does the recurrent implantation failure actually happens, or maybe some statistical miracle? Because they say that if you perform embryo transfers, the embryo is going to implant somewhere in the time, but you need to have many transfers to do that. So how can we manage to have that information, and how are the principal causes of recurrent pregnancy loss? And you can say that 30% of those recurrent pregnancy loss are due to anatomical problems in the uterus, for example. But there's no, we don't have to forget that the fertility process and the pregnancy process is quite complex, and there may be another causes of infertility that may or not be related to some uterine factors, and it represents a problem in order to design the perfect study in order to assess those techniques that may help us to do or perform or have success in our pregnancies. And this is the destiny of an embryo. If an embryo is euploid, is genetically euploid, you can expect, if the endometrium is good, that you get a successful pregnancy. But if the endometrium, even if the embryo is good and is genetically perfect, you will have an implantation failure. And this endometrium may not be ready if we do some harm in that endometrium, precisely because of a surgery or a laparoscopy or whatever, or maybe even that wasn't the problem of the patient. And if an embryo is aneuploid, it is not genetically good, the endometrium has selectivity, and the endometrium can select if the embryo is going to implant or not, or maybe the endometrium lets that embryo to implant, but after some weeks, the patient gets a miscarriage. So we need to go back to the basics. So there's some markers that may show how, or may represent with good sensitivity and specificity if the embryo is going to implant. But look at this study. Look at what the markers are. Actually, the markers are morphological, and they are performed by ultrasound. And if you have those differences between the ultrasound, between an receptive endometrium and a less receptive endometrium, you may see something easy to measure, like, for example, the endometrium thickness between 7 and 15. And if you have that thickness, you may expect a 99% sensitivity, accuracy, and 3% of specificity that embryo is going to implant. Also, the endometrial volume, and also the endometrial pattern, that trilaminar pattern that we like to see in our patients that we may lose because of surgery, a hysteroscopy, or something like that. It is really important in order to assess if a embryo is going to implant in that uterus. And there are some other markers. Look at that. For example, that 100% of sensitivity with 8% of specificity in the endometrial blood flow. And something that we may not stop in order to see when we are performing an ultrasound in our patient, for example, the endometrial contractions. If we wait just a little bit when we are performing our ultrasound and we look for the contractions, we may think that if with a 94% of specificity, that our embryo, if the patient doesn't show those contractions, are going to implant or not. And we may do something in order to prevent that contraction of the uterus. So remember, for example, when we have a fibroid over there, that the contractility may be higher than usual, and those are the things that may affect the implantation, that we can't do something else for our patients. Also, the look of the endometrium directly by an hysteroscopy, and the pattern of that endometrium is really important. And what can we do in those pathologies, fibroids, that we have been talking all the conference about fibroids, intramural, and adenomyosis, and all of that. What can we do for that patient in order to enhance its implantation and not to harm or harm less than the disease itself? So we need to think outside the box. We need to think, well, I think that we need to think outside the traditional way of doing things, the traditional way of performing surgery, hysteroscopy, and to have an open mind in order to see those minimal invasive techniques that may help us. And you may find some knowledge from the most unexpected places, as I found that knowledge in a cider can in Canada. And they say, just think outside the box. Just think. There's no box. So we need to think about that. Thank you.